All right, so just to introduce myself, I'm Dr. Laurie Grossberg. I am a gastroenterologist. I specialize in taking care of patients with Crohn's and colitis. I work at Lahey Hospital, and I'm just gonna share my screen with you now. All right, can everybody see this? Okay. So today I'm going to talk about health maintenance and IBD and review what you guys should know. And again, like Jenna had mentioned, if you have any questions throughout the talk that come up, feel free to write them in the chat box and I will try to cover as many as possible at the end of the session today. Okay, so, all right, so today I'm going to talk about, first I'm going to talk about vaccines and preventing infection. We'll review cervical cancer screening, skin cancer screening, bone health and disease. We'll talk about smoking cessation and depression and anxiety. One thing that is also very important, of course, is colon cancer screening. I'm not planning to cover that today in our talk. I think that's a whole separate area of discussion, but if you have any specific questions, I can also try to answer those as well. So why is health maintenance and IBD so important? Well, patients with IBD have been shown to not receive preventative services at the same rate as the general medical patients. And this may be because patients with IBD are seeing their gastroenterologist frequently, that they don't always get to see their primary care doctor as often. They have low immunization rates. They take medications that have potential adverse effects. So we often think about biologics or immunomodulators being associated with a possible increased risk of infection, but actually steroids also have a lot of potential adverse effects as well, including infection, bone issues, and eye issues. So they're very important to pay attention to. Patients with IBD are at increased risk of osteoporosis and fracture, and have an increased risk for depression and anxiety. So there's a lot to consider. So first I'm going to talk about vaccines and IBD. We're going to talk about why they're so important, which ones patients with IBD should get, and if there are some vaccines that patients with IBD should not receive. So why are vaccines so important? Well, infection is an adverse event among immunosuppressed IBD patients, and this risk of infection increases with the number of immunosuppressive therapies. Several of these infections are preventable through vaccinations. Vaccines do not affect disease activity of IBD, and there can be a diminished response to vaccines in patients on treatment. So it's important to think about this early on in your disease course. Infections are more common in patients with IBD. So the incidence of flu is actually higher in patients with IBD, and complications have been shown to be more severe. And this is just some data I'm going to review over the next couple of slides showing this information. So on the left here, you can see patients with UC, Crohn's, or all IBD, and they're in the black bar. And the control group is patients without IBD. And you can see that the incidence of flu is higher in patients with IBD. And then on the right, it shows that these complications of flu, such as pneumonia or hospitalization, again, are higher among patients with IBD. Data also shows that the incidence of pneumonia may be higher. Again, the darker bars are patients with IBD compared to non-IBD. Streptococcus pneumoniae, or pneumococcus, is a bacterial infection. It's a common cause of sepsis, pneumonia, meningitis, and middle ear infections. And immunosuppressed patients are at higher risk of this. And herpes zoster, or shingles, is greater among IBD patients than controls. And again, here on the left, a study is showing that patients with IBD in the darker bars are at higher risk of getting shingles compared to those that are in the gray bar. And when you break this down by age, so age is on this bottom line here, with increasing age, you can see there's an increased risk of shingles. But even within each age group, you can see that patients with Crohn's and UC are at higher risk of getting shingles. And these are in the black bar and the lighter gray here. Okay. And unfortunately, patients with IBD have been shown to be inadequately vaccinated. So this was data from a survey study of, I think, 169 patients with IBD. I believe the majority of them were on immunosuppressive therapies or had been on immunosuppressive therapies. And when they looked at the patients that were at risk, and they saw that only a small proportion, the orange, was vaccinated. And there's a lot of different reasons for this, but one survey showed that GIs thought that it was really the primary care physician who was responsible for giving the vaccines. But on the flip side, many family care providers felt, only a small proportion really felt comfortable making recommendations for vaccinating IBD patients. So it really is kind of a shared responsibility between the GI and the primary care, and it's important that there's good communication between both. Here I'm just showing you, I know this is a bit busy, but this is what the CDC recommends for vaccines for everybody. So the yellow bars represent recommended vaccines for all adults, and then the purple is for patients with an additional risk factor or indication, which often includes IBD. And then this is that same kind of recommendation from the CDC, but broken down by medical conditions. And I put a black rectangle around immunocompromised. And this is, because many patients with IBD fall into this category. So again, the yellow is what's recommended for everybody, the purple for some patients, but you can also see there's red bars here too. So there's some vaccines that are not recommended, and we'll review all of this. So which vaccine should patients with IBD get? So IBD is rare before age 5. So most patients do receive their typical childhood vaccines. And then for adults, regardless of immunosuppression, they should receive all non-live vaccines in accordance with national guidelines. And here is just a table showing all of the non-live vaccines that are typically recommended. So I'll go through each of them. So influenza or flu, patients should get every year. Tetanus or tetanus with pertussis is given every 10 years. HPV is given as a 3-dose series, and this is recommended for patients, I think typically age 11 or 12 get it, recommended through age 26, and now there's new guidelines that say patients between age 27 and 45 also may be eligible to get this vaccine based on kind of shared discussion with their primary care or GYN. The PCV13 and the PPSV23 are both pneumococcal or pneumonia vaccines, and both are recommended for patients with IBD. So the Prevnar or the PCV13 is typically given once, and it's usually given first. And then the pneumococcal vaccine, the PPSV23 or the Pneumovax, this is given either 1 year after the PCV13, or it can be given as quickly as 8 weeks after the PCV13 if you're immunocompromised. And then this is usually given a booster after 5 years and again at age 65. Hepatitis A and B are also vaccine series that are recommended, and the shingles vaccine is recommended over age 50. This vaccine, the Shingrix, is the inactivated version. There are 2 different shingles vaccines, but the one that is inactivated is again called Shingrix and recommended at age 50. One other vaccine that's not on this table is the meningococcal vaccine, so the meningitis vaccine that is recommended as well. So which vaccine should IBD patients not receive? So live vaccines are generally contraindicated in patients that are immune suppressed. And live vaccines include the intranasal flu vaccine, MMR, which is the measles, mumps, and rubella vaccine, varicella, or the chickenpox vaccine, yellow fever, and then herpes zoster or Zostavax is a live shingles vaccine. It was kind of a earlier version of the shingles vaccine. This is not recommended for patients that are immune suppressed. And some exceptions are that this live shingles vaccine could potentially be given to patients on low-dose immunosuppression, which includes low dose of prednisone, methotrexate, azathioprine, or 6-MP. And then patients who are on vedolizumab also may receive live vaccines if the risk outweighs the benefit. If the benefit outweighs the risk. So special circumstances, it is okay to vaccinate household contacts of immunosuppressed IBD patients with live vaccines. So babies often get rotavirus vaccine, and it's just important that you're very careful with washing your hands with diaper changes. And varicella or zoster live vaccines can be given to household contacts. However, if that member develops a vaccine-related rash, then you would have to be careful with contact with that patient, with that person. And then another thing to think about is, so for moms who are on biologics, infants cannot receive live vaccines. So the rotavirus is a live vaccine given to babies that should be deferred 6 months in moms who are on biologics. And lastly, vaccines for immunosuppressed travelers. So if I don't think it really applies to anybody right now, but if you do have a big trip planned in the future, it's important that you talk with your travel clinic and kind of go through everything and make sure that you're protected and have the appropriate vaccines. Cancer prevention. So first we're going to talk about cervical cancer, and then we'll go into skin cancer. We'll talk about if there's increased risk among patients with IBD and what patients can do for prevention. So cervical cancer is related to infection with HPV, and some other risk factors include smoking and compromised immune systems. And most studies do show that there is a slight increased risk of cervical cancer in immunosuppressed female patients with IBD. The ACOG guidelines, which is the American College of Gynecology, these are kind of what PCPs typically follow with their routine practice, and these don't apply for patients that are immune compromised. So that's important to remember. But it does recommend that patients or women who are ages 21 to 29 should get a pap test every 3 years, and then patients that are between 30 and 65 can get pap plus HPV testing every 5 years, or a pap alone every 3 years. But the ACG guidelines, which are one of our guidelines, the American College of Gastroenterology, recommend that women with IBD and immunosuppression should get annual cervical cancer screening. So this is really something that should be discussed with your PCP, your GYN, whoever's doing your PAPs, that perhaps you should be getting them a little bit more frequently than the standard recommendations. So patients should make sure that they're having this conversation and that they are up to date. And of course, the HPV vaccine, if you're eligible, you should talk about getting that as well. Next, we'll go on to skin cancer. So is there an increased risk? So skin cancer, 1 in 5 Americans will develop, but by age 70, it's very common. Non-melanoma skin cancer, this includes squamous cell and basal cell skin cancers, are very common. The most common was shown that 3.3 million people were diagnosed in 2012, and that there was no documented increased risk among non-melanoma skin cancer in patients with IBD. However, melanoma skin cancer, while it's less common than non-melanoma skin cancer, it is more serious, and there has been some studies that have shown a slight increased risk among patients with IBD. So some IBD medications can increase your risk of skin cancer. Thiopurines, and this is 6-MP, mercaptopurine, azathioprine, Imuran. These are thiopurines. They're associated with non-melanoma skin cancer. While anti-TNFs, which include adalimumab, infliximab, certolizumab, golimumab, these are associated with an increased risk of melanoma skin cancer. This is just the data from one study that looked at patients who were on 5-ASA or mesalamines, anti-TNF, and thiopurines, and they looked at the risk of them developing melanoma versus non-melanoma, and they showed that patients on anti-TNF had a slightly increased risk of developing melanoma, and those on thiopurines, non-melanoma. And on the right here, you can see that we're looking at patients who have taken thiopurine, either are on it currently, which is the black, were on it before and stopped it, or the white is they never took thiopurines, and kind of looking at it with age. So you can see that non-melanoma skin cancer does increase with age, but patients who were taking thiopurines and even patients who previously took them and stopped, that there is a slight increased risk of developing and non-melanoma skin cancer. So we do, of course, recommend standard prevention that, you should be wearing your sunscreen and avoiding indoor tanning and trying to, keep yourself protected. That you should be aware of any new changing skin growths on self-exam. So if you do notice something that looks funny or it's changing, that you get that checked out. And we recommend an annual skin exam, especially if you're on some type of immunosuppression. And this can be done with either your primary care doctor or with a dermatologist. Next, we'll move on to bone health. So why are patients with IBD at increased risk for bone problems? What can patients do to prevent bone problems? And how should my doctor be monitoring my bones? So first, why are patients with IBD at increased risk for bone problems? So it's estimated that somewhere between 14 and 40% of patients will have osteoporosis, and these causes include steroids and just overall systemic effects of chronic inflammation that can kind of impact normal bone metabolism. Patients are at risk for calcium and vitamin D deficiencies. So vitamin D is actually absorbed in the small intestine, and so patients who have small bowel Crohn's or have had a surgery before are at higher risk of having a vitamin D deficiency. Malnutrition increases risk for bone problems, and then overall other risk factors that are the same with the general population: older age, low BMI, females, smoking, alcohol, all of these things can contribute to bone issues. So it's important to make sure that you talk to your gastroenterologist and develop a plan to develop a way to taper off your steroids if you're on steroids because of their increased risk associated with bone issues. Make sure that you're getting enough calcium and vitamin D in your diet. If you smoke, that you stop smoking, that you're exercising, and we do recommend minimizing caffeine and alcohol as well. And how should my doctor be monitoring my bones? Well, it's important that your doctor check your vitamin D levels at least once to make sure that you're adequate. And if you're not, that they can recommend getting an appropriate supplement for you. And then a DEXA scan or a bone density scan. And these scans should be done in patients who are postmenopausal or older men, patients that have had a history of fracture, more likely a low impact fracture. If they've taken steroids for more than 3 consecutive months, if there's a family history of osteoporosis, or if they're malnourished or very thin, you might think about getting a bone density scan earlier than age 65 or 70. And so patients at increased risk should get this bone density. And then if the bone density scan shows osteopenia, which is low bone density, or osteoporosis, then it's recommended for preventative measures, making sure you're getting enough calcium and vitamin D, doing those weight-bearing exercises, trying to limit caffeine and alcohol, and then kind of monitoring this over time to make sure that there's no progression. Or if there is osteoporosis, there are therapies available for that, and we usually refer you to a bone specialist or endocrinologist to discuss going on some medications and getting closer monitoring. So cigarette smoking. Does cigarette smoking impact disease activity in IBD? And the answer is yes. So patients with ulcerative colitis, smoking is actually protective, but of course smoking carries risks, so it's not something that we recommend. But if you do have UC and you are going to quit smoking, you should, be aware that there is some association with potential for increased flare if you quit. And so you should be aware of new symptoms that develop and make sure that you contact your doctor. On the flip side, in patients with Crohn, smoking's actually been associated with worsening disease, development of the disease progression, and poor medical and surgical outcomes. And smoking cessation actually is associated with a lower risk of flare, lower need for steroids and medication, and less risk for recurrent disease and reoperation. So if you are smoking, there are many different ways to think about quitting. There are lots of different nicotine replacement products. There's over-the-counter patches, gums, and lozenges. There's prescription versions and patches, inhalers, or sprays. There are prescription non-nicotine medications that can be helpful with smoking cessation. So this is something that you can talk with your primary care doctor about. And then of course, both, counseling on smoking cessation and medication are both effective, but they're really most effective when used together. And lastly, depression and anxiety in IBD are patients at increased risk, and what can patients and doctors do? So there is an increased risk of depression and anxiety in patients with IBD. It's 2 to 3 times more common. And there's so many different reasons for this, including the relapsing nature of the disease. Patients experience severe symptoms, the need for surgery, medication side effects. And IBD patients with depression and anxiety are more likely to have report more severe symptoms, undergo more testing, have active disease and relapse, require hospitalization, and may have a lower compliance with treatment. And so it's very important that this is addressed. And unfortunately, studies have shown that these symptoms in IBD patients remain largely untreated. So it's very important that we are screening for depression and anxiety. And during your visits, you may get asked questions such as, have you felt down, depressed, or hopeless, or had little interest in doing things? Or to screen for anxiety, have you been continually worried or anxious about a number of different events or activities in your daily life? And if you are having these symptoms, it's very important to talk to your providers. And your providers can refer you to a mental health professional. They can recommend medications or refer you back to your primary care doctor for further discussion. There are mindfulness-based therapies, and there are plenty of different resources available, many that you can find on the Crohn's and Colitis website, of different support groups and resources to help find a mental health professional. So just to summarize, today we talked about vaccines and preventing infection, and we talked about making sure that you're up to date on all of your standard non-live vaccines. It's very helpful if you have a record of your vaccines to bring them to your doctor and make sure that they have it, in their system and can help you to get everything that you need. We talked about cervical cancer screening and making sure that you're, getting your PAPs regularly, the HPV vaccine. We talked about skin cancer screening and getting an annual skin exam. We talked about bone health and disease and making sure that your doctor is recognizing if you've had any risk factors for developing, low bone density or osteoporosis, and potentially getting you a bone density scan, as well as checking your vitamin D levels to make sure you're getting appropriate supplementation. And of course, we want to help with smoking cessation and talking with you about depression, anxiety, and if you do have symptoms, helping you to get the support and help that you need. So that's all I have today. If you have any questions, happy to take those now. Let me just look at the chat here.
Yeah, there were a couple questions that came through the chat. I think the first one, well, just to address this, the slides will be going out and the recordings from the program. I think that was Gail, so thank you for asking that question. And the next one was, how do you feel about the potential COVID-19 vaccination when taking Humira for Crohn's disease?
So I think we'll have to get a little bit more information about the vaccine if and when it comes out. If it is a inactivated vaccine, it should be safe for patients with Crohn's and UC, regardless of your immunosuppression. So it would be recommended. I'm not sure how the rollout will be, but I imagine that people who are at higher risk will get the vaccine earlier. I hope so. And so, I would recommend it when it's approved and safe. And if it's inactivated, that it should be okay for patients with IBD who are on immunosuppression. Okay.
Great. We also had come in through the chat box. What about taking bone density medications while on Humira?
That is totally fine. It's something that usually the primary care doctor or endocrinologist prescribe, and there should be no significant interactions with, being on an anti-TNF, and we would actually encourage you to take those. We would actually encourage you to take those medications because it's important to treat the bones.
Thank you. And I don't see any other questions in the chat box. No, one just came in. What about taking Shingrix or the Shingrix vaccine?
So the Shingrix vaccine is the inactivated vaccine for shingles, and that is recommended for everybody over age 50. It's a 2-shot series, and everybody should get that regardless of immunosuppression. I'm not sure if this was in relation to the question about bone density medications, but also fine to get Shingrix with bone density medications as well. The shingles vaccine, actually, there are some people that, or some data, I guess, that there is an increased risk of shingles, especially with taking tofacitinib or Xeljanz. And some gastroenterologists are actually giving Shingrix vaccination to people younger than age 50 who are planning to start tofacitinib because of that increased risk as well. So that's another thing to think about that I didn't mention.
And Laurie, it looks like there's the timer up top has 5 minutes and 45 seconds left, which is shorter than what we anticipated. But we are trying to see if we can extend the time a little bit. But just, I don't have any other questions that I see in the chat box. I don't know if anyone has other questions for Dr. Grossberg. No questions?
Any other questions? Happy to answer anything.
Well, it's wonderful to have you on here this morning. This has been fantastic. And as we shared, we'll be sending out the slides and the recordings. And I don't think there's anything else planned after this. So no questions. I can't see many faces. Holly, thank you for bravely turning your camera on.
Well, thank you all for coming today, and thank you for having me here to speak. It was excellent, and enjoy the rest of the day and the extra hour.
All right, thank you.